Thank you to UICC for the opportunity to discuss this important topic of universal health coverage, why it matters to cancer patients, providers, and our community. To begin, I have no potential conflicts of interest to disclose. When we look at the broad landscape of cancer prevention and control in low and middle-income countries, we know that unfortunately a majority of cancer patients are not surviving their diagnosis. If we take, for example, a sample population of 1 million individuals, on average, there will be about 3,000 cancer cases each year. We can estimate that only about 700 people will survive that diagnosis because of low coverage, advanced stage disease, and low quality services. But at the same time, money is being spent. Governments are paying for cancer services to some extent, communities, hospitals, and of course, individuals. With this as our starting point, we recognize that governments are financing some cancer care. However, we know that is currently both inefficient and insufficient to meet the growing cancer burden. And as a consequence, patients are suffering high out-of-pocket expenditure while suffering poor outcomes. So the question we have to answer is, how can universal health coverage improve care, promote coverage, ensure financial protection, and offer every cancer patient the best possible outcome? In the next 20 minutes, we'll work to address those questions through these three specific items. To begin with the definition of what is universal health coverage. Then to look at the landscape of what are the political commitments that governments have made at the recent UN high-level meeting on UHC and in other fora that guide this advancement towards universal health coverage. And finally, to ask the question of what can each of us do as stakeholders in the cancer community to promote universal health coverage and its effective implementation. To begin with the question of what is universal health coverage. The WHO definition of UHC is that all people and communities can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. It is, in short, a principle that maximizes population coverage of cancer or other health services that provide value for money while ensuring that they are accessible, quality, and affordable. The three simple parameters to consider: access to quality care when it is needed and without suffering financial hardship. Oftentimes, universal health coverage is broken down into three dimensions to help us understand how a specific program can work towards universal health coverage by asking these questions: what services, who will receive those services, and how much will be paid? To begin with the question of what services. Within the cancer community, the objective is for all cancer prevention, diagnosis, treatment, and palliative care services to be available to any cancer patient. However, recognizing that governments have limited resources for health, what are the priority interventions that should be included within a universal health coverage scheme? This process of defining what are the priority interventions is known as defining the benefit package. It is achieved through a three-step process of informed data to identify health priorities, a broad stakeholder dialogue, and a final decision from an appropriate governing authority. To begin, the first step is using data to identify what are health priorities. Historically, the principle of cost effectiveness has been used as the guiding parameter to identify health priorities. In practice, other principles should be used that include, for example, fairness and equity, acceptability, budget impact, and financial risk protection. This process of using data to inform health priorities is a process that should be done with as few conflicts of interest as possible, because the objective is to use data across disease groups, across different settings, and across different communities to identify a shared set of priorities. Once these health priorities are identified, a broader stakeholder dialogue is undertaken to ensure that the process has legitimacy, transparency, inclusiveness, and accountability. And it is in this stakeholder dialogue process where discussions are had on what are the specific needs for vulnerable populations and others who may have lacked a voice in the broader discussion on data. And then finally, a decision must be made by an appropriate governing authority that has a legal mandate to decide what are the final interventions that should be included in a benefit package, with the recognition that this authority should reflect the citizen's voice. From the WHO perspective, we've started with the exercise of defining what are some of the most impactful interventions that all governments should include within their benefit package, a process that has been identified and known as the best buy for tackling NCDs, non-communicable diseases. This is the beginning of a broader program of work to define what are the specific priority interventions that each country should consider according to their epidemiologic burden and their context. The next question is, who will receive these services? Again, the objective is to ensure that everyone can receive cancer services regardless of precondition. But there are considerations that have to be made regarding capacity. That is, coverage can be proportional to the service available. We see in some middle-income countries that coverage can be scaled up rapidly. This often is the result of investments in health systems to ensure that there are enough providers, enough hospitals, enough medicines and technologies. When we look at the current landscape, however, for cancer in low and lower middle-income countries, we see that there remain significant deficits in the basic availability of services, that is, the coverage of key cancer services such as surgery, chemotherapy, and radiotherapy. And given this context, the principle as coverage is further complicated, that this is only a question of are the services accessible. It does not consider quality or financial protection. These are covered in some part to the last dimension, which is how much will be paid. And the objective, again, is to minimize user fees to ensure financial protection. The goal with user fees is to minimize the financial catastrophe that often occurs with cancer. Now, how to achieve that is a point of great discussion. It has been shown that there are diverse revenue sources that can be considered to finance healthcare. The financing mechanism is not necessarily the important output for this dimension. What is critically important is the percent of people that suffer financial catastrophe or financial harm. You can see in the table on the left portion of the screen a sample of countries that have reported the number of individuals who suffer financial harm from a cancer diagnosis. And as you can see, the concerning statistics reflect that many cancer patients are selling their homes, selling their personal possessions to access care. This is not consistent with the principle of universal health coverage and an important parameter for us to consider when developing systems that can in fact achieve universal health coverage aligned with the three dimensions as presented. We can ask ourselves, why does it matter? Why is universal health coverage so important in cancer? There was an excellent study that was produced in 2016 in The Lancet and demonstrated that for countries that have achieved universal health coverage, they in fact are able to deliver better health outcomes, particularly during economic downturns. That is, the most vulnerable segments of the population can still access high-quality cancer care, even at times when resources may be limited. This reinforced the principle that universal health coverage is a cyclical investment. It leads to stronger health systems and, in fact, will ultimately achieve better cancer outcomes. As the immediate past Director General said of the WHO, Dr. Margaret Chan, universal health coverage is the most powerful concept that public health has to offer. Now, universal health coverage is not a point in time when governments can easily raise a flag and say, we have reached the pinnacle of universal health coverage. When we look at the landscape of high-income countries, we see that universal health coverage really is a journey and not an endpoint. In fact, in some countries, it took the better part of 50, 70, or 100 years to achieve 100% coverage with financial protection. And even when that is achieved, particularly in disease programs like cancer, where there are rapid discoveries, this principle of universal health coverage will change. What, in fact, are the services that should be included? For example, should some of the innovative cancer therapies be included in a benefit package? And these are some of the questions that governments of all income levels are grappling with as they try to maintain a universal health coverage scheme for health services. So what is it that governments need to do? We know when we look at 4 key objectives, there are existing major obstacles that governments have to consider. As a starting point, we know that Current health expenditure is insufficient, particularly in low and middle-income countries. The estimated gap is approximately $146 billion per year. As a second point, we know that service organization or service structure often compromise outcomes for rural populations and those that are poor because accessing high-quality cancer care is difficult. We know that that financial protection for the set of priority interventions often leaves people with out-of-pocket expenditure that forces them and their families into poverty when it is not appropriately compensated for from public funds. And then finally, we know that governments, while increasingly investing in health, are still subjected to significant inefficiencies. WHO in the past has estimated that 20 to 40% of health spending is wasted. So what can governments do? On the screen, you can see that there are some potential interventions in each of these four parameters. For example, promoting public health functions, investing in prevention to reduce downscale investments that may be needed for treatment and palliative care. We see governments increasing investments in primary care to facilitate earlier diagnosis and access to more advanced therapies for rural populations. We see the principles of equity and the need for equity to guide the definition of priority interventions in a country, health technology agencies increasingly being used to evaluate priorities. And finally, for there to be stronger data systems to ensure that programs that are implemented are done so effectively and while minimizing inefficiencies and corruption that often result in wasted healthcare dollars. Above all these four guiding principles, we know that political will is needed. Now, political will is a broad concept. The definition is listed on the screen. But what is most important for the stakeholders attending the Leaders Summit is to recognize we all have a voice in generating political will. Politicians, patients, civil society, providers, and other stakeholders. To achieve those four parameters, there is a key voice that each of us must contribute to promote universal health coverage in our countries and in our settings. So what is it that governments have committed to with this increasing recognition that the political will is being generated at the global level? As some of you may know, just last month, governments from around the world reconvened in New York at the United Nations to commit themselves to universal health coverage in what is known as moving together to build a healthier world, building on commitments that have been already made in the 2030 Agenda for Sustainable Development. Two quotes just to highlight how important of a meeting this was. The Secretary General of the UN stated that this was the most comprehensive agreement ever reached on global health, a vision for universal health coverage by 2030. The Director General of the WHO stated that UHC is a political choice, that today's world leaders have signaled their readiness to make that choice. And this is now where we, as the cancer community, can pick up the ball and ensure that all cancer patients are covered through a universal health coverage scheme. There is a long history of UHC. In fact, it dates back over 5,000 years with the recognition that governments and communities have a responsibility to promote health within their populations. The late 19th and early 20th century was the beginning of public healthcare services for broader populations. It was first defined or first recognized as a formal government system in the 19th century in Germany, and from that process forward, we saw many countries take up the program of public healthcare services. Then, universal health coverage really found its voice in the 1978 Alma-Ata Declaration, which introduced this principle of health for all. This was the beginning of universal health coverage in the modern era. Then, 4 years ago, governments formalized that commitment in the Sustainable Development Goals, for which universal health coverage is one of the health-related targets. And since then, we have increasingly seen governments and regions make this commitment in a more concrete way in the progression towards a more formal universal health coverage scheme in their countries. Now, what happened 1 month ago that was particularly unique? As a starting point, some may say, well, cancer wasn't highlighted within the political declaration, but in fact, that wasn't the objective. The objective was to highlight that these are cross-cutting investments that governments must make to ensure health for all. And it is worthwhile to notice that non-communicable diseases were broadly mentioned 3 times in the political declaration, increasingly highlighting the recognition governments have that NCDs, including cancer, are a reigning public health concern. Tangibly, governments committed to develop national targets for universal health coverage by 2020 and to re-emphasize their resolve to reach UHC by 2030 as committed in the Sustainable Development Goal. This included the commitment to cover 1 billion more people by 2023, which aligns with the WHO triple billion target. Specifically, governments want to focus in the short term on the rise of out-of-pocket expenditure, a point of particular relevance in the cancer community. At the same time, the UN was asked to commit to providing coordinated support across different UN agencies, for which the WHO will act as the host for a multi-agency network. The UN also committed to host a follow-up meeting at the UN high-level meeting of 2023, where UHC will again be presented. So what is it that we can do as a community as we look forward to the next 4 years and towards the 2030 target? There are 4 specific activities that we can consider as a community. How can we support defining priority interventions? How can we contribute to expanding coverage? How can we ensure financial protection? And how can we promote quality? To begin with that example again, where 700 lives can be saved for that 1 million population, as a starting point, we as a community can help governments identify what are the most impactful interventions to include in a benefit package, recognizing that some of the commitments and investments that have been made to date may not have yielded the return that we have hoped. An example is providing a targeted therapy without investing in the pathology to identify who would benefit from that targeted therapy, or investing in a screening program but not ensuring that diagnosis and treatment are available. If we, in fact, take the money that's currently allocated for cancer and focus on priority interventions that are cost-effective and promote equity, we can, in fact, save more lives and do so at a lower overall cost. And this dialogue on how to identify a priority package of services is an exercise that WHO and IARC have taken on, working with other UN agencies to help governments in a specific context understand what are some of the priority interventions that should be included in that country's benefit package. To give a brief example of how far we have to go and some of the challenges we're currently facing, is that we still find governments are undertaking cancer programs that are not based on the best evidence. When we look, for example, at breast cancer screening, we found that a significant percentage of countries are screening populations that are younger than 40 or 50. And we know that this is not cost-effective and yields a significant inefficient expenditure in cancer care. These are the types of exercises where the cancer community must come together and focus on investing in best practices, in evidence-based policies and programs to ensure that money that is spent in cancer is done so effectively. Second is the recognition that expanding coverage is the guiding principle and the most short-term effective way to improve population outcomes for cancer. If we were to give 2 scenarios to help inform what it means to expand coverage. In scenario number 1, if a government has to decide between increasing participation in cervical cancer screening or starting a new program for breast cancer screening, which is a more appropriate investment? Or a second scenario, if a government must decide between introducing a new targeted therapy for lung cancer or increase the number of women who are receiving trastuzumab, which is the better investment. And we know that, again, by starting with priority interventions and promoting population coverage, governments can ensure that the greatest population health can be achieved. So expanding coverage is the most important guiding principle for ensuring cancer services are optimized at the population level. Next is to work together to promote financial protection. We do know that cancer is an expensive disease, but it does not need to be prohibitively expensive. And when done well, the financial consequences can in fact be low. Cancer can be seen as an important health system investment rather than an overall cost. We know that countries, as you can see in the graph on the screen right, are spending increasing amounts of cancer, even disproportional to the broader disease burden in the country. But what is important is for us to develop a consensus as a community as to how can we ensure that the patients are not suffering the consequences for the increased complexities and costs of cancer care. One important starting parameter is for us to more accurately monitor out-of-pocket expenditures for our patients by having discussions with them and with public agencies to understand what are the out-of-pocket costs that cancer patients may be subject to and how can we as a community minimize them, when in fact there are a variety of mechanisms to do so. Another important parameter for us to focus on as we progress towards universal health coverage is to understand the importance of quality. If we look, for example, on the screen figure on the right-hand side, we see that on the y-axis, maternal mortality rate, on the x-axis, institutional births. We would expect that countries that have a high proportion of institutional births, that is, women delivering in a hospital, should have the lowest maternal mortality rate. But in fact, what we find is that the correlation is very weak. As the immediate past Director General of the WHO has said, what good does it do to offer free maternal care and have a high proportion of babies delivered in health facilities if the quality of care is substandard or even dangerous? For us in cancer, we know this is also a very relevant question. What good does it do to offer cancer care if a patient requires a re-excision after initial operation, or if they suffer a complication from a medicine that was not handled or administered appropriately? These are the challenges that each of us as stakeholders in the communities can focus on. How can we improve quality within our specific programs and areas of work? When we look at the consequences, we see, comparing outcomes from two countries, that stage-specific survival can be as profoundly different as 10 to 20%. And these are countries where the available treatment is not significantly different, for example, the management of cervical cancer. This then raises the question of quality. We can estimate then that approximately 15 to 25% of survival gaps can be explained by low quality, which translates to 1 to 2 million lives per year. This has massive consequences for outcomes and expenditures in cancer. Why? Well, a discussion on why quality of cancer care can be low is a complex one, but just to begin, workforce capacity, out-of-date practice guidelines, and a failure to coordinate services as 3 sample reasons. And finally, with that as our guiding principle, universal health coverage, what is it that each of us can do? We have the 4 guiding principles. How does this then translate to questions or actions that each of us should take? To begin, defining a package of services. We can ask ourselves as a community, what treatment should be prioritized? What services are truly essential? What should be prioritized in the first phase? And what should be potential opportunities for scale-up? Then, what can we do to promote coverage? How can we reach the vulnerable? How we organize services? How we structure the facilities geographically? How we coordinated care between those facilities? Are there interventions that can increase efficiency? For example, can we improve the efficiency of a pathology lab by using telepathology? And if so, can we use that as a mechanism to promote population coverage? Financial protection. What are patients able to afford? How can we use public funds to support the gaps that patients are currently being subjected to paying out of pocket for cancer services? How can we advocate for our patients in the public sphere to minimize out-of-pocket expenditure? And then finally, what can we each do to prioritize quality? How can we disseminate best practices? What contributions can we make to multidisciplinary care, recognizing that it is beyond just the voice of providers that is needed, in fact is the voice of patients, communities, policymakers that is required for us to develop high-quality cancer programs. With that as our platform, we have a unique opportunity as a community to improve cancer care for all through the mechanism of universal health coverage. We look forward to the discussions that will take place at the upcoming World Cancer Leader Summit in Nur Sultan, and very much appreciate the opportunity for UICC to facilitate this dialogue at the global level using the World Cancer Leader Summit as the forum. We look forward to greeting you there, and thank you again for your attention and concern.